All right, so I want to thank Axel and Dave for inviting me and give you an overview about immunotherapy and gastrointestinal cancers in 19 minutes and 35 seconds. And so that's a daunting task. So we'll really go through just a high-level overview about what do we know. There's a lot of things actually we do not know. But this is an exciting time, at least from the clinical standpoint, to move forward with immune therapies in GI cancers. All right, so first discussion will be about the PD-L1 and the CTLA-4 inhibitors, and that's certainly the obvious since these are the most advanced, at least in terms of moving forward in gastrointestinal cancers. So first, start with a discussion about microsatellite instability and the relationship between MSI, which is really the main driver in our clinics at least, for the choice of immune therapies, and tumor-associated inflammatory responses. So what MSI high is, it's just a surrogate for hypermutation. So what that means essentially is MSI high tumors tend to have a load of mutations, 10 to 100 times increase in the mutation load versus the MMR proficient tumors. And that essentially will lead to the massive neoantigen expression on tumor cells, and that essentially leads to robust tumor-associated inflammatory responses and ultimately lead to responses to these PD-1, PD-L1 inhibitors by essentially increasing the tumor infiltrating inflammatory cells around the tumor and the tumor environment. When we look at mismatch repair deficiency across tumor types, and this essentially was published in Science by Dong Li. Gastric cancer, just looking at the GI cancers, gastric cancer seems to lead the pack, at least from that study, followed by small intestinal, colorectal, and then you can see pancreas cancer somewhere around here, mostly in the later stages. So MSI high does exist in pancreas cancer. It's at a very low rate, likely less than 1%. But primarily gastric and then small intestinal and colorectal. When you look, on the other hand, at the tumor mutational burden, and looking specifically at breakdown among GI cancers, right-sided colon cancer, again, seems to lead the pack, which makes sense. This is where most MSI high expression tends to hold, then followed by gastric. You can see left-sided, actually, colon cancers on this side, and then you have the rest of the cancers. Pancreas cancer tends to be on the lowest side of immune therapy. Of tumor mutational burden, 1% or less, which again is not surprising, at least from the clinical standpoint, knowing what we know the role of these agents in patients with various GI malignancies. So when looking at the relationship between MSI, tumor mutation load, and PD-L1, as you know, in lung cancer, for example, PD-L1 is almost a must before using these agents, but that doesn't seem to correlate always well with tumor mutation load, which is the primary driver for our GI cancers, or with MSI. Same as you can see, PD-L1 primarily, the circle is outside the intersection with the TML and with the MSI. Interestingly, when we look at colorectal cancer now, what you see a perfect, almost a near perfect overlap between high tumor mutation load and MSI high, and really disconnected from PD-L1 expression, which essentially means that MSI high is a good surrogate for a high tumor mutation load, and high tumor mutation load is primarily present in tumors with MSI high expression, not 100%, but close enough. But PD-L1 expression is probably meaningless in this group of patients. All right, so what do we know about pembrolizumab? So the PD-1 monoclonal antibody in MMR deficient colorectal cancer. This was from the initial study presented and then published by Dong Li. This was eventually published in New England Journal of Medicine. And the first analysis of the response was before 20 weeks, and there was essentially a response rate of 57%, a number of CRs, 11% CRs, and then PRs, and stable disease prolonged. There were few progressors, very few progressors, so disease control rate about 90%. This was in the proficient tumors. You can see no responses. There were few stable diseases, but primarily the majority of the patients progressed. When you look at the median PFS and OS, they were not reached with the MMRD, and they were, as you would expect it for this refractory group of patients, for the MMRP. So this data was updated, and this was updated essentially at 24 plus weeks of responses, and these are a little bit off. I apologize about that. But what that shows you, the top portion of the waterfall plot is essentially the best response, and then the blue is the 20-week response, and then the best response was in orange. What that means essentially is a number of responses continue to solidify through the course of therapy, and beyond 24 weeks, many partial responses became complete responses, actually north of 20%, and many stable disease patients became partial responders and perhaps complete responders. Quite impressive. I mean, if you look at the bottom of the waterfall plot, you can see what % of patients actually ended up in complete response and how many continue to trend that way. In other words, what that means essentially is that the best response is not necessarily the one you're going to see in the first few weeks or even the first 12 to 20 weeks, but some of the responses become solidly present beyond 20 weeks. And then when you look at the number of different cancers, in red are the colorectal cancers, and there are a couple, the blues here, or the purples, I'm sorry, were the pancreas cancer. There were 2 pancreas cancer patients with MSI high phenotype that actually ended up with a complete response. In fact, one of those patients was my clinic patient, entered on that trial, ended up with a complete response after failing chemotherapy, and had to stop the drug for toxicities a year after she started, and she 3.5 years at this point with a complete response, doing fantastic. So these are very impressive results, but they do apply for a small % of patients in the GI malignancy world. In colorectal cancer, 3 to 4%. In pancreas cancer, maybe 0.5%. In advanced gastric cancer, 3 to 4%. In the earlier stages, of course, there's a larger % of these MSI high. So certainly this helped move the PD-1, PD-L1 inhibitors, so PD-L1 inhibitor atezolizumab plus FOLFOX into the adjuvant setting. This is a phase 3 trial run through Alliance, through the intergroup, Atomic, and looking at MSI high patients with stage 3 colorectal cancer. This is led by Frank Sinicrope. So how about the data on in other GI malignancies? This was the Keynote 059, which led to the approval of pembrolizumab in patients with gastric and GE cancers. There were 3 cohorts to this study. Cohort 1 had more or equal than 2 prior lines of chemotherapy. They were PD-L1 positive and negative, so regardless of PD-L1. Cohort 2 had no prior therapy, again, positive or negative, and cohort 3, no prior therapy, and was PD-L1 positive and was single agent. For cohort 1 and 3 were single agent. Cohort 2 was a combination of pembro plus cisplatin 5-FU-capecitabine. Attraction, the other data we have from gastric and gastroesophageal cancer comes from Attraction 2, which essentially looked at nivolumab versus placebo in gastric and gastroesophageal cancers. This particular study was run in an Asian population and essentially did show an improvement with nivolumab versus placebo. The most intriguing part is although at the median perhaps the difference is a little bit tighter, you can see as you get to the tail of the curve beyond the year, there's about 20%, a little bit less than 20% of the patients that continue to be alive in this very refractory setting versus a complete flattening around the placebo. So there is certainly from this a suggestion that nivolumab or PD-1 inhibitors in general do seem to benefit few patients a lot and most patients a little bit to none. So going back to Keynote 059, the patients with the 3 different cohorts, remember cohort 2 was the cohort that essentially included the chemotherapy plus pembrolizumab. Looking at the response rates, essentially 2 things stand out. One, in cohort 1, which is the pre-treated patient population, there was a response rate of 12%. In the earlier stages, that response rate seems to be double that of the more refractory patients. In cohort 2, with the chemotherapy plus pembrolizumab, there was a 60% response rate, which is relatively high in this group of patients, and these are the PFSs and the OS. Of course, the group that had MSI high in the refractory setting ended up driving most of the responses in the refractory setting. I mean, there were a small number of patients, 7, but they had close to 60% response rate. I mean, that's consistent with what we'd expect with the MSI high, but overall, there was a signal there, and it led to the approval of this agent in gastric cancer in the United States. However, a follow-up study to that was Keynote 061. I was running at the same time. And this was a randomized phase 3 trial looking at pembrolizumab versus paclitaxel. The primary endpoint was overall survival and PFS in PD-L1 positive patients. And just based on the press release, and we still have to see the full data, the trial seemed to have missed its primary endpoint with a hazard ratio for OS of 0.82. And that was not statistically significant, and the same, no significant improvement in progression-free survival. So a negative trial. So the phase 2 trial looked interesting, led to an FDA approval. The phase 3 trial, unfortunately, came back negative. Mind you that the comparator arm was paclitaxel, which we know underperforms to paclitaxel plus ramucirumab, which is a bit concerning, certainly when looking at this, and make a blanket statement about these PD-1 inhibitors in that setting, and rather perhaps still consider those as somewhat for the more refractory patients after failing multiple standards. The other study, Javelin study with avelumab versus, again, drug of choice, paclitaxel, docetaxel, was also negative, meaning that it didn't reach its primary endpoint. Very similar design, again, trying to introduce this line of agents into second line and third line gastric cancer, both negative at the phase 3 level, which really puts in question, are we selecting the right patients in clinic based on a phase 2 study? What does the phase 3 study tell us? So we're looking forward to see more results from these studies to learn a little bit more. Now, how about advanced HCC? We know nivolumab was looked at again in a phase 2 study, large phase 2 study, did show some interesting response rates regardless of viral infection, close to 20% response rate, but we're awaiting the phase 3 study. This, again, led to an approval by the FDA, but there is a phase 3 study ongoing comparing nivolumab to sorafenib in the first line, and there's another one with pembro versus best supportive care. These are the current approvals for PD-1 monoclonal antibodies in GI cancers. Of course, the MSI high across the board. There's not even a question mark that this is a good place for them. In HCC, right now it's second line after sorafenib, but we are waiting to see the results of these PD-1 inhibitors versus standard of care or best supportive care in HCC, and colorectal cancer primarily for MSI high, and then gastric cancer third line for PD-L1 positive, although again 2 negative phase 3 studies. So in terms of thinking about how to enhance the efficacy of anti-PD-1, PD-L1 blockade, there are multiple strategies that are being looked at. The ones that are leading the pack are targeting CTLA-4, but also others as OX40 and LAG3, and then certainly other ways to manipulate the immune milieu, injecting viruses into target tumors, vaccines, and a number of other experimental therapies. When looking at ipilimumab, a CTLA-4 monoclonal antibody plus nivolumab in MSI-high colon cancer. Again, this was a non-randomized study, but looking essentially on the left versus the right, this was nivo alone, so my left. And this was nivo plus ipi. You can see that the waterfall plot looks somewhat more favorable with the nivo plus ipi. And then the PFS per investigators, again, looks a little bit more favorable with nivo plus ipi versus nivo alone. Mind you that just looking at the Dong Li paper from Science, it's obvious that there are patients who do fantastic with PD-1 inhibitors alone, and they really do not need the addition of a CTLA-4. In fact, you can argue that close to half of them would never need another agent and may never need actually chemotherapy when they move to if we move to the first line. So the question, who are those patients who may need that extra agent with extra toxicities and extra cost? And certainly that study needs to happen so we can understand who are those patients who may need that additional agent versus single agent PD-1. Same was looked at in gastric cancer with nivo plus ipi-3, nivo 3 plus ipi-1. And as you can see, and again, this was somewhat of a randomized study. There were some allocation pieces to it, so it wasn't a traditional randomized trial. But nonetheless, when you look at the PFS, at least, doesn't look much different between all three, although there may be a little bit advantage for the nivo plus ipi at the survival, especially the nivo plus ipi-3. Slight maybe. Overall, though, I think that strategy is of questionable value right now and needs to continue to be explored beyond this study. So other ways to essentially enhance the activity of PD-L1, bringing some of these advantages we've seen with the PD-1 inhibitors in the MSI-high tumors is, at least in colorectal cancer, try to look at PD-L1 plus MEK inhibition. MEK inhibitors are non-specific immunomodulatory agents. They essentially technically inflame the tumor, invite those tumor-infiltrating lymphocytes, and make them, at least theoretically, more susceptible to these PD-1 inhibitors. The phase 1b of atezolizumab plus cobimetinib, which is a MEK inhibitor, was updated, presented at ASCO GI. This is the study that led essentially to a phase 3 study looking at the combo versus regorafenib versus single-agent PD-L1 inhibitor. Response rate was about 8%, so it was a little bit lower than what the study was initially presented, with a stable disease 23%. The disease control rate was about 31%, so overall less impressive than what was initially presented. And, we are waiting for the phase 3 data. The study is complete, and we're hoping a report somewhere in the summer. Another agent of interest are those bispecific T-cell engagers, the BiTEs, and these essentially, are linkers. They link essentially the T-cell to the tumor cell, so they have two domains that do that bring them together. This study was presented at ASCO in 2017, looking at the CA-TCB, which is essentially T-cell bispecific antibody, as a single agent, and then in combination with atezolizumab. And this study did show some really interesting activity with the CA-TCB with atezolizumab. In fact, some of these patients are shown here. One of the patients had a significant response at week 4, at least metabolic response, and the scans at week 16 showed near complete resolution of the tumors. These are heavily pretreated patients. Very interesting study, and that there's a possibility this may move into the phase 3. So going beyond PD-1 and CTLA-4, a number of ways to target the tumor, as I said, at multiple levels of this cell immune cycling. Using both co-stimulatory or co-inhibitory ligand receptor pairs. All these strategies are being looked at in early clinical trials, have not yet panned out to larger studies, but are on their way. IDO inhibitors are, of course, very interesting. They're another target that essentially increases the level of antigen presentation, acts at the level of the dendritic cells, and enhances the activity of PD-1 inhibitors, looks promising in melanoma, and in making its way into colorectal pancreas cancer. Oncolytic viral immunotherapy is another interesting domain. We know there's TVEC, which has made its way into melanoma, but also being looked at in GI malignancy, specifically colorectal. The whole principle is you inject the virus into one of the tumor cells, it multiplies, breaks down the cells, releases all these neoantigens, and essentially releases also the viruses which infect other cancer cells. So it's a domino effect at the virus level, but it also inflames the whole immune system theoretically, and then brings the power of the immune system combined with PD-1 inhibitors. There may be an opportunity to essentially enhance the activity of PD-1s or PD-1 inhibitors in patients who technically wouldn't respond to PD-1 inhibitors, such as MSS or non-colorectal cancers. And finally, of course, the CAR T cells are starting to make their way into GI malignancies. All right, so I will conclude very quickly here. So this is an exciting time, although we have a lot of promise, but we also have a lot of disappointments. The work continues, looking mostly at combining multimodality immune therapies, and of course, the challenge of understanding what is tumor response and when is the optimal tumor response remain. Vaccines, I haven't gone through those, but they have been so far overall disappointing in colorectal, pancreas, and other cancers. Thank you.